So my name is Joe McVeigh. I'm head of physiotherapy in University College Cork in Ireland, and I'm part of the XR for Rehab network. I'm absolutely delighted to introduce our speaker today. So Beth Kenny is a senior physiotherapist and a senior research associate in trauma and orthopaedics at St George's University Hospital in London. Beth has been qualified as a physiotherapist for about 10 years and been specialising in trauma and orthopaedics for this last 5 years. Beth has a special interest in non-pharmacological management of pain in the acute hospital setting, and she is currently doing her MRes in clinical research at St George's University Hospital. And I'm assured that she's due to start a PhD in the not too distant future with some of our colleagues in St George's. So Beth is going to share her insights into the use of virtual reality in acute orthopedics trauma. Really looking forward to your presentation, Beth. I know trying to get VR, XR technology into the clinical setting is a major challenge. I'm really looking forward to hearing your experience and your insights. So with no further ado, as I say, I'll pass over to Beth.
Thanks, Joe. Yes, so I'm going to do my very best effort at taking you guys through what we've been up to at St George's Hospital and what I've been up to, kind of looking at why using VR in the orthopaedic trauma setting might be useful. And please, like Joe said, there's going to be a Q&A at the end. So please bring your questions and your comments and your thoughts. It's an evolving process for me still. So I still have new thoughts every day. So, work away with the questions. Right. I think my slides are moving, so we're good. So what I'm going to do is I'm going to show you, explain how we're using it in trauma and orthopedics. I'm going to explain why we're using it and bring in a bit of the evidence around why we would use it in a trauma and orthopedic setting. We've done a quality improvement project at St George's, and we'll touch on that. And with that in mind, I'll talk to you about some of the opportunities that have potentially come from that, or what I'm thinking. And then I'm also going to touch on some of the challenges about maybe taking the project further and thinking about implementation into an NHS health setting. First, so I'm going to I don't know necessarily the audience and how much we know about virtual reality and extended reality. So I am going to touch on the definition, and mostly because I think this is really important when it comes to looking at the loads of research that is out there. Extended reality is an umbrella term, and underneath the umbrella sits this world of augmented virtual reality and different devices. And it's quite different healthcare researchers will interpret, when you're reading the literature, virtual reality in different ways. So an example would be that the Nintendo Wii Fit is often described of a form of non-immersive virtual reality. And as you probably more commonly are familiar with, we've got these head-mounted displays, which is also another type of virtual reality, and that is deemed more immersive. So there's lots of terminology around extended reality. And when we're looking at it in the literature, it's going to be really important, if you're interpreting a paper, to go what type of virtual reality or extended reality was this researcher using, or in any project that's utilizing virtual reality, what does that mean? Now, my interest is in the head-mounted displays that are hitting the high streets. I think Apple's just bought one out that is supposed to be very impressive. And in our trust, we're using a head-mounted display, which is a Pico head-mounted display, and we're using it via a company called Zinc VR Medical, which provides software and different types of applications. What's exciting about these head-mounted displays is that they're becoming quite cheap and accessible, and therefore there's that opportunity to start using it in the healthcare setting. Just to touch on immersion, I've got the word immersion up on the slide here. Like I said, you've got Nintendo Wii that is non-immersive, and you've got these head-mounted displays that are more immersive. And this is something that often comes up in the research as well when we're looking at how effective VR or the future VR devices might be in helping our different populations. What it's basically saying is the more we're excluding our environment, potentially the more immersed a person becomes, and could that be more distracting and beneficial when we're starting, when we're giving these patients these experiences. And at the moment, I think that's still up for debate in the literature, but some studies would say that it is, and some would say that it isn't. And I'll touch on that a little bit more. Okay. So why have we been using it at St George's? I'm going to show you a little video in a second. Hopefully you can hear it okay. But briefly, I work in trauma and orthopaedics. There's some lovely recent guidelines that came out in 2022 that highlight that we need to promote early mobilisation. We've come across these virtual reality headsets. I was introduced to Sync VR about 2 years ago now, and they offer a form of software that allows people to get moving whilst wearing these devices. They'll play games and exercises, and it will help promote the moving. So we decided that could we feasibly put these on our patients and help them get moving in the trauma and orthopaedic setting. So that's what we've been looking at, and our idea is to try and promote early mobilisation. There's lots of evidence out there, like I've already touched on. I did a literature search the other day on systematic reviews looking at the use of VR in rehabilitation, and I think I got about 140 systematic reviews that exist out there using VR for physical rehab in different populations. So there's tons of evidence. It's very mixed quality, but it is very promising on what it can use, what it can do for people. And that might be pain, it might be getting them moving. So there's lots out there. I'm going to touch on that more, but for now I'm just going to start by playing the video. I've just got to move it along a little bit, so just bear with me.
Can take a long time and be very painful.
I'm just, Joe, give me a thumbs up if you could hear that briefly. Can't hear Joe, but I think he's saying yes.
I can hear it perfectly. Thanks, Beth.
Perfect.
Physios are trialing using virtual reality to distract patients from pain when they move.
Which means they
That was me.
can exercise at their bedside by playing games through a headset. Our reporter Carl Mercer has been to meet some patients who are going through this kind of rehab at the major trauma ward at St George's Hospital in Tooting in London.
So what are you sorting at the moment? What's the fruit on the go?
Oranges, apples, bananas and kiwis.
I have to get used to my hands now. Ooh, feels quite weird.
It is perhaps not what you'd expect to see on a major trauma ward, but Becky and Jack are loving their new toys.
It's not just nice because it's something to do, it's also fun, which is the main thing.
Yeah.
You don't get a lot of fun in hospitals.
You don't feel like you're in a hospital. It's good for your mental state, and also I can really feel the stretching, strengthen up the upper part of my body.
It's good. It's making you stretch. Yeah, because we want her to stretch. We want her to get a little bit out of breath. Put it the other way around.
Trauma physios Ellie and Beth are using virtual reality games to try and help Becky, whose horse fell on her, and Jack, who had a motorbike accident, in their rehab.
So for Jack, who's got some pelvic injuries, it can be really painful to sit and to support their own sitting balance. So in this position, Jack's able to engage his core and tummy muscles, to reach forwards and lean outside of an area that might be comfortable kind of for him, to push through a little bit of a mental pain barrier, and put the fruit in all the corresponding baskets as well.
Go in the right basket. Yes, rehab is painful, but at the same time it's ultimately good for you. So being able to have that mixture of it's fun and also good for you, it is something a little bit different from just normal of, right, we're going to drag you out of bed today and we'll walk you down the hole. So
We're just going to reset your feet get this heel as far back as possible. Okay, and off you go.
Because you're just concentrating on the objects that I'm trying to get to. I'm more focused on that in a way, and you sort of almost forget what you're doing. Not doing, but you know, you think, okay, I'm not in hospital as such, sort of thing. Yeah, it's nice.
Using the VR games, they think, helps take the patient's mind off any pain the exercise can cause.
I think the main thing with patients like Rebecca is that they have been through something that was scary, they had an injury, and sometimes that's a memory that stays with them. And then having to get up and move can be quite worrying, and you think you might make your injury worse. And doing something like this, when you're just doing some basic normal reaching and leading movements, can give you that reassurance that actually it is okay to move.
So far, they've used the technique on around 50 patients with encouraging results. They now want to bid for more research funding to expand their trial.
It's Carl Mercer reporting from the hospital in Tooting. It's quite bizarre, isn't it? Seeing somebody
watching
Okay, I'm
someone
going
do.
to stop that, or we'll go on to the rest of the news. So hopefully that touches on why we've been using
It's at
trauma.
6:28. Time to get the news.
Bear with me. I'm trying to move slides. There we go. So hopefully that touches on why we've been using it. It sounds like something exciting is happening outside my street. I don't know if you can hear all the sirens. So if you can, it's adding to the trauma experience. So these patients, we've been trying to use it as much as we can with any of our major trauma population. And I touched on the different types of virtual reality that there exists, and that being the devices. You know, we're using a head-mounted display, and on that head-mounted display, what we have is 2 different types of software. So my focus is on the physically active type of software. So you can see up on this slide, we've got VR as an adjunct for rehabilitation, and it's referring to the software Sync VR Fit. And we're doing that more therapy-led. So the physios and our occupational therapists will apply this to our major trauma patients on the ward. We do have also the relax and distract type software. So that is the sort of software where you're just being played a video, you're not necessarily interacting with your environment, you're watching something nice and relaxing, and there might be some background music. Now at St George's, what we're doing is our psychology team are leading on that more. So they're frequently going to the patient's bedside and just letting them use the VR experience and chill out and relax, and hopefully distract them from the hospital environment. And then what I'm doing is I'm trying to get people actually moving with the VR headset and engaging in their rehabilitation. Now, the evidence that exists out there, another thing that you need to be careful of when you're reading these papers is asking yourself what type of software are they using? So not only what device are they using, what software are they using? So there's lots of evidence out there kind of justifying the use of the relax and distract type software, and that we know that could potentially help patients in acute pain, chronic pain, patients with anxiety, patients that are about to have procedures and are anticipating that discomfort, people that just need distracting from maybe a wound or a dressing change. And we know that the relax and distract apps can help with that sort of thing. The VR-based exercise therapy, there is research out there. Again, it's mixed quality, but we are seeing that it's promising with things like improving acute pain, helping patients with chronic painful conditions. It's helping patients with their functional ability. One of the things that I'm very interested with our trauma population is that fear of movement. And as you can see here, that it is also improved. There is evidence to suggest that it's helpful for kinesiophobia. There's a systematic review that looks at kinesiophobia, and what was interesting is that in that paper, it actually suggested that the less immersive type of VR was actually beneficial from what they investigated. But what we have to bear in mind there is that was on a lot of the older VR devices and not the modern devices. But it also commented that it was the VR with the active component that was superior in the studies. So it had to be virtual reality where patients were moving more, showed slightly more benefit with kinesiophobia, which makes sense. But those devices, when you deep dive into that systematic review more, those devices are more like the Nintendo Wii Fit. And actually, that's potentially great and accessible in an outpatient setting, but I know, thinking about my hospital setting, the Nintendo Wii Fit is pretty challenging to take onto a ward environment. So what I'm hoping is that as the technology and software evolves with the head-mounted displays, is that we're seeing more exciting opportunities with the software getting patients moving, and then it will be interesting to see what the future research projects with that in mind. So just briefly how we think it works. So there's a lot of thought out there. So simplistically, distraction is the most common reason why we think VR is beneficial, particularly with pain, so in reference to pain. So it's suggesting that we're distracting patients, we're taking their attention away from something, and with that diverted attention and focusing on something else, they have less pain. There's also this concept of, so we've got the distraction, let's park that for a second, but there's also Gupta et al. Who looked at the fact whether there is a neurophysiological change, which might be more long-term, so we can distract people in the short term, but long-term we actually are potentially changing the pain threshold, the pain tolerance, patients' confidence to move in pain. And this is the bit that interests me more, like I said, is that, okay, what I want to see from my trauma population is that, okay, it was good for them, it distracted them, like our patients said, they perhaps felt less pain in the moment, but also it gave them that confidence to move, so it changed their perception of pain. And hopefully that has more of a long-term effect on patients' outcomes. Gupta and his colleagues also look at fibromyalgia patients and highlighted that what they found is, in conjunction with some other therapies, so like CBT, that the patients were still in pain, but actually they were able to live in that pain better, having had VR and a conjunction of other therapies. So VR's use in trauma, in terms of what the literature offers, there isn't lots of it out there. And the studies are small and they're often not in an NHS setting. So there's some military-based ones which were very military specific, that had headwear which potentially involved experiencing a firearm as well. But I've just drawn on two studies here. So Morris, he used 60 patients with, he had traumatic brain injury. They used actually a more modern version of head-mounted display, and they found it to be safe with their trauma populations, which was reassuring when we were looking at whether we could use it with our trauma population. And they found that it had a modest tangible effect, analgesic effect, so it's helpful for patients with pain. Hoffman was a study carried out in the USA. It was actually just a single case study, but I draw on this because highlights one way that it could be used, is that they applied it to a patient with extensive soft tissue injuries, degloving around their pelvic area, and they were looking at whether it might have a tangible effect on their patients' range of movement. And they found that when they were wearing the VR, as opposed to just doing their standard range of movement exercises without anything, it decreased their pain intensity, and it decreased their time thinking about pain decreased. And then there was also a functional improvement in their range of movement. It has, so my area of interest has more been the major trauma population, but just for anyone generally working in orthopaedics, and I do work in orthopaedics, there is literature out there on its use in ankle injuries and knee arthroplasty. So there's some systematic reviews and meta-analysis there. Here's 2 examples. The evidence is low quality. The devices used are very mixed. So again, it was not just head-mounted display, it was Nintendo Wii, Xbox Kinect, and it showed some reassuring benefits and highlights how VR probably has a place in this setting, but we need bigger, larger studies that can really show how it impacts patients. So one of the things that we've been doing on the ward is considering putting on patients with CPM who are having continuous passive movement with knee arthroplasties. This study here by Gazandum in 2023 touches on that and shows that it can be beneficial. Notice that there wasn't actually necessarily long-term significant effects on pain scores, but actually it was beneficial for their function. And then with the orthopaedic ankle injuries, what this study showed is that there were some benefits with balance and gait speed, but not so much with muscle power and proprioception, but we had some improvements, but again, low quality studies. Right, I'm going to talk to you about our quality improvement project now. So we started this around January 2023. Formally, we've captured 55 patients using the VR headset and collected outcome measures. We've done the project in 2 waves. So the first wave involved a patient survey, and then the second wave, we tried to collect some more validated outcome measures. So I'm going to talk to you a little bit about what we found from that. We did have a bit of an inclusion-exclusion criteria. We did keep it quite broad because one of our main aims was actually to learn how feasible it was to use with our patients. And if we were then anticipating that lots of patients, or maybe they wouldn't, that might hurt them, we weren't necessarily going to be trying to expose as many of our trauma patients as possible. So our tact was that we would approach anyone that was TARN eligible only if they had obvious trauma around the face that would worsen an injury. We wouldn't do it. We were a little bit flexible with that. So for instance, if someone had a broken nose, you might think that they might not tolerate it wearing the headset, but providing they weren't significant fractures, we would hold the headset up to the patient and see how they found it. So our main aim was to go, okay, we've got a very mixed population here. They might have rib fractures, they might have pelvic fractures, they might even have upper limb injuries. Who can we feasibly apply it to, and how will it help them? So the data so far. So like I said, our main aim was to see what injury profile of patients could tolerate using it. So the first graph on the left-hand side shows that actually we used it on predominantly polytrauma patients. And on the right-hand side, we're breaking down what sort of injuries did those polytrauma patients have. And what we're seeing here is that a lot of it was thoracic injuries, spinal fractures, and pelvic fractures, and lower limb injuries. And what, just to touch on that a bit, so you could, more specifically, what we're using it with even now, so outside of this data collection, where I'm most commonly using it, is those patients with rib fractures that need to maybe get a little bit out of breath, lean and reach, and perhaps and the patients that are struggling to sit. So if they've got a pelvic injury, or they're going through something called dangling, where they might have extensive soft tissue and injury and had plastic surgery, and they need to sit up with their legs dangling over the edge of the bed, we're applying it a lot in that scenario as well. And anecdotally, we've seen that's been very helpful for them. So we did capture complications. There were no major complications. We had some, we always asked, I've split this up into patient, clinician and safety. So the minor safety things we had was the odd cannula came dislodged. So one was a nasal specs and one was that we did the terrible physio crime of accidentally pulling out a cannula, but I've done that I confess I've done that not using a VR headset. And then we asked the clinicians when they were going to use the VR headset, did they have any concerns? So we had a few concerns about falling and the patient's spatial awareness, and one was concerned that the patient would get breathless, but that was mitigated. And then we had 5 patients who kind of had said that it was quite a bit heavy and they get claustrophobia. And then there were some patients that had said that it was a bit too painful, but when there was one of those that tried it again a few days later and it was fine. So in the first wave of data collection, we asked a survey to 18 people. And what this shows is that most people didn't find it at all stressful. And then we had most people didn't find that it was painful. It was motivating them, so extremely motivating, and it did help engage them in their rehabilitation. And what I was most interested in was, did it facilitate their movement? And most people agreed that it did facilitate their movement. Have a lovely word cloud here that my colleague made. So we also asked patients to say 3 words that they thought that they associated with using the VR, and lots of positive words here. So fun, escapism, distraction. And then the main theme of the patient feedback was probably this concept of immersion they liked. So they found it took them away from the hospital environment. It was, a welcome break from the hospital vibe. In the bottom right, you've got someone commenting on the fact that they felt it did change their pain threshold and help them overcome more, which is what we're hypothesizing it might be useful for. It's not for everyone, and this chap stated that it was hot and bothering and he would have enjoyed it 10 years ago. So there we go. So here we are trying to capture some more validated outcome measures. And so based on the fact that what we were observing was that people were finding that it was helping facilitate their movement whilst they're in pain, and that perhaps those that were more anxious, we were able to distract them with. We looked at 3 validated outcome measures. On the right-hand side here, I've just specifically highlighted what would be deemed clinically relevant. So with the pain catastrophizing scale, for people need to score more than 30 to be deemed to be having a clinically relevant pain catastrophizing. That surprised us that actually the pain catastrophizing here isn't deemed clinically relevant, but what we do observe our patients on the ward is that they often feel anxious about the pain and, perhaps overinflate that and are worried. So actually we didn't see a clinically relevant change from pre-VR. It was, but it did decrease. We should bear in mind that these outcome measures that we used are used in lots of different settings and not necessarily validated in a acute trauma setting. Kinesiophobia, what we found is that patients did have a clinically high level of kinesiophobia on the ward, and it did reduce by about 3 to 4 points. So, and that can be in the literature deemed clinically meaningful, that reduction. Anxiety-wise, we saw a little bit of a reduction, but actually it was interesting when you were listening and engaging to the patients, we did a post-score near to them being discharged, and actually a lot of them were getting very anxious about the concept of being discharged and going home. So I think food for thought on this, and feel free to make comments or ask questions. But if we're trying to measure the kind of benefits of virtual reality, how we do that and how we do that with validated outcome measures is going to pose a challenge in the major trauma setting, particularly, because we don't have great outcome measures for this specific thing. And also, I think perhaps on reflection, we've maybe jumped the gun, and what we need to consider is more about how the intervention is helping people, what they feel it's helping them with, and then looking at whether, and then taking the research forward from there. So one of my agendas at the moment is that within my MRES, I am going to be doing a qualitative study, asking patients specifically what they feel the intervention helped them with. So those that have used the VR headset on our major trauma ward, I'm inviting them to be interviewed. So watch this space, and that might actually, based on what they're saying, then can we measure something more objectively. We did use the global rating of change scale as well, where people are kind of asked to rate their overall change. Obviously, we haven't got a control group to compare it with. We were delighted to see that it was a +4 score if they felt moderately better. It would be worrying if it reduced, because obviously our whole rehabilitation was encompassed in that score. So the challenges. So I kind of touched on a challenge there. So this is partly where my head is at the moment, on how we are going to show, or do we need to show how beneficial VR could be in this trauma orthopaedic setting. So I say how. So how do I do that? And heterogeneity comes into this, because like any research in major trauma, we're dealing with a population where it's very, very mixed. So you've got patients with rib fractures, pelvic fractures, head injuries, a combination of those things. And so to kind of say where it's useful and to do a whole study on that is quite challenging. There's also heterogeneity within the current research as well, which I drew on. There's loads of different devices. There's lots of, I think there'll be even more devices evolving in the next 5 years, and there's lots of different software. Targeting treatment. So I mentioned this because the studies that have been done, some of them have highlighted that we do need to have that individualized approach. And I was thinking about this a lot yesterday, sort of how we know this, that in reality, we're not just going to apply, if we prove that virtual reality in major trauma is this brilliant, amazing thing, we're still not necessarily in our acute ward setting going to apply it to someone every single day. We're going to look at the patient that needs it and where we think it's going to help them, and then we're going to utilize the VR for that person. And you know, when I was looking at in our quality improvement project, when we were looking at whether it was going to help someone with their pain catastrophizing or with their kinesiophobia, we need to only do that on the patients that do have a high level of that in the first place. So sort of like how the start back tool in back pain was designed to kind of help pick the patients that would actually benefit. We need to consider that when we're looking at future research projects or showing how it might benefit people. So there's the challenges of specifically in major trauma and thinking about how we take on future projects, but then there's also the challenges that Joe sort of, when he was introducing, touched on, which is that challenge implementing it in the NHS generally. So I've been liaising with a couple of trauma units at the moment that are also interested in getting a virtual reality headset. And actually, the first hurdle they're going through is actually getting a headset physically to use with patients. So there's, you know, the time it takes to do that, showing that it's beneficial is what the people with the purse strings wanting to know, and often they're faced with this, money is the reason we can't do it. Lots of people going through charitable funds to try and do this and have been successful in that, but it is a barrier to trying to lift off any project on virtual reality in the NHS. I've just put this slide up just to show that with our quality improvement work, we have done some patient and public involvement, and obviously that's really important for any project that we're doing. So we did invite people to St George's to ask them about how we might take our project further, and patients felt that it was it was a good idea. They had some concerns about maybe having to answer too many questionnaires or anything like that, and their stance on it was that they'd much rather be directly asked or interviewed about it, and hence I'm embarking on that journey right now. And that was our PPI project poster boy, and he did use VR throughout his major trauma journey to good effect. So the VR future, so quality improvement project, we're just doing our 3rd cycle, and we're hoping to engage other trauma units in that. I'm doing a qualitative interview study, and I'm also doing a systematic review looking at the use of VR in the acute hospital setting, and specifically active virtual reality. And then, what's the future? Could it be a randomized controlled trial? Watch this space, we'll see. I have lots of references that I'm sure if you want, I can share.
Thank you, Bethany. Thank you so much. That was really, really interesting, and some great work. Absolutely, it's a real challenge to get technology like this here into the clinical setting, and particularly within that acute orthopaedic setting. I think it's really groundbreaking work that you're doing. So thanks a million for sharing that. As I say, that the presentation will be available on the XR for Rehab website. Please, by all means, download that and have a look at it again. I'll open the floor for any questions. If anybody has any questions, please post them in the chat there. But I'll maybe start off. And you touched on the difficulties in getting this into the clinical setting. Could you tell me how you were able to do that so successfully with your colleagues? Was there any resistance? Was it embraced? What were the challenges around, embracing new technology and new techniques and so on? So tell me a little bit about that.
Yeah, we were really lucky, because when we were invited by Sync VR to try using it with major trauma patients, so they sort of gave us a 6-month free run at doing it, and we showed that it could be done. So that was good. We showed that yes, it's very feasible to use virtual reality. I think in the first wave of the project, my colleague, and I think when I was talking about the inclusion-exclusion criteria, I probably was maybe more hung up on that than you might wonder why I was hung up on that. But I think in terms of what you said about people's impressions of it, we would every morning when we're allocating patients, we'd say, is anyone appropriate for VR? And a lot of my colleagues were like, oh no, I don't think that person could do it. There was that assumption, oh no, and actually it was my other colleague that sort of broke the mold on that and said, well why? Like the point of a feasibility is actually try using it. So invite the patient, are they okay to do it, and would they like to try using it? And then if we then find in applying it, we can't, because there might be something that's not safe or anything, just like any physiotherapy adjunct we use, we would risk assess whether that individual can do it. And then if we came across issues, then we would stop. And I think that was one of the key things that, we talked about as a team, is to try and be open-minded with its application and actually invite the people to try using it and then go from there.
And you can see that safety always comes up. Safety comes up as an issue every time we talk about it, and quite reasonable. But again, as you say, you do that risk assessment. If it's feasible, then you can step forward with it and see if it works. I have a question on the Q&A. I'm curious about the potential crossover between VR applications in post-amputation care. Could VR solutions for trauma also benefit amputee patients undergoing prosthetic training, particularly in addressing challenges like phantom limb pain?
That's a really interesting question. We actually had someone about a year ago from America talk to us about their work they were doing on virtual reality and phantom limb pain, and just generally kind of rehabilitating their amputees, but they had a focus on phantom limb pain. I can get the name and share it with you, Joe, because it might be an interesting speaker, but absolutely, from what I am aware, it is being used. It also gave us the courage to use it with some of our amputees a bit more. So we had a person that was a quadruple amputee, and I asked them how they were using their VR device with those patients. And actually, they said sometimes they would just strap the controllers to the residual limb. And we had a patient that was particularly happy to try that. So we bandaged the VR controllers to their arms, and then they were able to sit in the bed in long sitting, and it was like amazing workout for them. And they loved it because it gave them that kind of first kind of feeling of using their arms again in a more natural way, and they were able to do reaching and grabbing tasks. Obviously, there was limitations with the device because they couldn't use some of the clicking functions of the device, but there were games on our device where you didn't need to have that.
Yeah, and thanks for that, Beth. And I do recall we had a presentation at, and again, just a plug for our annual conference. We have an annual conference every year. Next year it's in Milan, outside Milan, Lake Como, I think. Sylvia will correct me later. But you're all welcome to attend. But there was a presentation at that a couple of years ago, and again, our colleague was demonstrating that in using in patients with amputation and specifically phantom limb pain, as far as I recall. So there is work that's going on in that. I have another question from my old friend and colleague, Louis, and he asks, has it been rolled out in outpatient trauma orthopaedic outpatient settings yet?
Not at our site, and I don't know if other units are exploring its use. What we have got a major trauma class where we were, that is an outpatient class that we were kind of thinking, could it be helpful in, but we haven't rolled it out yet. Yeah. So watch this space. I don't know if anyone else has experience of that.
One would imagine it would be, you would face less challenges in the outpatient setting rather than, I'm sure Louis will attest to the times that I've caught a chest drain and dragged the poor patient out of the bed, but maybe don't get that in outpatient settings.
I mean, I think for me, like we had a visitor come in and look at the VR device and how we were using it on the ward, and they very much wanted to take it. They were like, oh, well, could they use this in the community? And I was like, well, practically in terms of certainly the NHS community setting, I know that this is being done, but no, we're not going to send people home with a VR headset into the community. Where I feel passionate is this is an adjunct. It's not a replacement for therapy, to get them moving and give them the confidence to move. And if we can show that in the acute setting, when we send these patients home who are very worried about going home and progressing with their own rehab and fearful of moving, hopefully we've given them that kind of acute sort of education that it's safe to move, they can move, and then hopefully there's less complications down the line, and then hand over to our amazing outpatient trauma colleagues that are going to take them further in their rehabilitation.
I have another couple of questions here. A colleague asks, they're very interested to know if VR would be helpful in improving gait patterns and cerebral palsy. And I know that members of the XR for Rehab consortium have worked in that area. And again, I would recommend that they go along and check out the website, and I'll see some information on that there. And Remco corrects me and tells me it's at Lecco beside Lake Como, our conference next year. and he's kindly put in the link in the website, so that's available for you. Is there any other questions or anything? Let's just let me check. I think you touched on a really important point there about outcome measures, and perhaps we're a wee bit obsessed about outcome measures, about having to demonstrate effect immediately. I think there's a discussion to be had around that, and to look at a little bit more globally about a physiotherapy intervention that may well include VR along with traditional physiotherapy interventions, and looking at outcomes more globally, rather than does this here improve kinesiophobia, or does this here improve range of movement 2 minutes after it's used. I think there's a discussion to be had around that, and around the use of outcome measures in the use of VR more generally. And that's maybe for another day.
Yeah. I think that maybe a more VR specific one. I'm not sure.
Yeah.
Even generally in major trauma, the outcome measure things keeps coming up recently, and I certainly don't have an articulate answer. I haven't stumbled on.
And there's nothing wrong with the soft outcomes as well. If somebody says, yeah, that feels better, sometimes that's not too bad. I don't think there are any other questions coming up, colleagues. If there's any other last questions, I'm happy to ask them. But if not, I'd like to thank Beth again. Thank you so much for your presentation. It was really, really interesting. The presentation will be available on the website, and the website is open for membership. If anybody wants to join in our general discussion about the use of VR, XR, and rehabilitation, you're more than welcome to join us and join our consortium, and we'd love to have you. And Beth, this isn't the last time we'll talk. We're a wee bit like the Hotel California. You sign out, but you can never leave. So we'll be in touch again. And
Thanks a lot, Jane.
Thanks a million. Thanks so much, colleagues. All the best.